And my patients were being monitored by the hepatologists, and we were told to go away, come back next year, your liver is not too bad. We were told it was not too much of a problem. But then suddenly in 2009 there was a shock for me. My friend and colleague Andy McWilliam found he had hepatitis C, went to have treatment with the old-fashioned interferon treatment, which cleared his virus, but then he was told the virus had gone, but he had liver cancer, and he died, 6 weeks later with teenage children. And this was a wake-up call for me. He was 52. I plodded on trying to get my patients to get in and have the treatments which were available, but they didn't cure everybody, and they had a lot of side effects. So I was delighted in 2015, as I say, to be offered this opportunity for my patients to be cured with tablets only, 8 weeks, 12 weeks course of treatment, and hepatitis C is cured, and we have a new vision for the future of a world without hepatitis C is possible. I'm going to show you the film now, which is only 1 minute and 20 seconds and just gives the headlines. The new strategy, the new virus hepatitis strategy. This is the 5-year, this is the paper version, you can see it online. They have vision to eliminate hepatitis. Hepatitis B, we can treat with vaccine. We can't cure hepatitis B, people live with it, but we can reduce the incidence of it through vaccination, and we can see that coming down. We can affect transmission from mother to child, and that's very effective. But now with hepatitis C, we have this brand new cure, and we have a new vision for the future. I need the clicker. Oh, I'm so sorry. Where's the clicker gone?
Here.
Aha. I'm so sorry. I thought I was going a bit slowly. Here's a graph which, okay, it's a funny graph, but it's from their strategy. The top line is hepatitis, is HIV. You can see that it going up and then coming down very effectively with UNAIDS and the WHO working hard. The strategies have been working. You can see the TB coming down. Unfortunately, it's levelling out a bit, but it is coming down. Malaria coming down. The one that crosses the line is the hepatitis, and it's going up. And this is why the world is looking at this problem and looking at it with some hope that we can turn that line down as well. But I'm afraid it will curl up before it comes down, because the people who've been living with hepatitis C for 3 or 4 decades are coming now with cirrhosis and with liver failure, and that's why we have this urgency. We need to move on. Here is the first global hepatitis report last year with the headline. They used to say, halfway down you can see it says 71 million living with chronic hepatitis C. They used to say 140 million, and they halved that last year because better testing shows that only 71 million actually have chronic hepatitis C, and some people are living with the antibody, but they've cleared the virus. But it's still a large target to hit. I'm not going to read all the words because you can look them up. The WHO wants us to emphasise on their slides that they are now supporting all the harm reduction measures which we understand, the needle syringe programme, the opiate substitute treatment which is needed for the key population of people who use drugs, to embrace and help them to come in and get treated for their hepatitis C. But they're also, the new thing they particularly want to stress is they're addressing stigma and discrimination. They're supporting legislative changes and policy, and not just the health measures, because these are also powerful and important. And they're saying that countries should decriminalise, work to decriminalise, because prisons are like a greenhouse for hepatitis and for HIV, and overcrowded prisons make this epidemic worse. And countries should work towards non-custodial strategies and work towards reducing prison overcrowding generally. This is the study that they did, that the WHO organised last year, which published in the Lancet in October, which is worth reading, which shows that 179 countries now report people who inject drugs. These initials, PWID, we're expected to understand all these strange initials, but people who inject drugs, it used to be, this is 30 countries more than we used to have. Only 93 of those have needle syringe programs. Some of them are very, very small numbers of syringes per head of population, and the WHO target of 200 syringes per person per year for people with HIV needs to increase to 300 syringes per person per year if we're going to help with reducing hepatitis C, because it's so much easier to catch, and there are other discussion about paraphernalia which is needed as well. Opiate substitute treatment is only in 86 countries available, and we know what a difference that can make to it. This is just the map. You can see the 93 countries with needle syringe program and the 86 countries with the. And so here we are. I'm rustling through this so that we can carry on with the discussion. The summary is that we need to focus not just on the health and the harm reduction policies that are needed in the countries and in regions to get to grips with this problem, but also with structural and policy and legal framework interventions in order to free the world of hepatitis. So that's the end of the WHO, I think. This is their vision in the end. By 2030 we should eliminate viral hepatitis as a major public health threat. And with our motivational interviewing hats on, we can perhaps say on a scale of 1 to 10, how likely are we by 2030 to have rid the world of hepatitis C? We might say maybe 2 or 3, but by the end of this meeting perhaps we might be saying maybe 6 or 7, and we can see a way forward. I'm going to introduce now, who am I going to introduce now? Sorry, Torbjørn from Norway, who will introduce himself and give the Norwegian perspective. Thank you.
Thank you, and thank you for inviting us, challenging us to both be a co-sponsor in the very last minute and to ask me to give some few words. I will try to. I'm not a doctor, I do not have any PP. This is a typical bureaucratic approach. It will be a boring, read-up statement, but please stay awake. This is the Norwegian perspective you have asked me to say something about, which I will try to. I think the facts are whatsoever, it will most likely be presented much better by the others than it will be me, so I will not say very much about that. But as it is worldwide, the prevalence of hepatitis C among people who use drugs remain extremely high also in Norway. And if this side event was to be held 3 months ago, with this regard, I would have been rather negative. But I think from the beginning I will be negative, but maybe I will be a little bit optimistic towards the end. Before I say something about the situation today, let me, however, go some years back in time. I was introduced to drugs back in 1985, but as an outreach worker in Oslo. And that was about the same time as the first injecting drug user was identified as HIV positive. And soon several others were also transmitted. This resulted in a kind of panic at several levels. And for those who were born at that time already, I think this mid-80s, it was a kind of panic for the HIV. We thought maybe the whole population would be deleted. Luckily, it's not gone that way. With regard to drug use, because there was only one pharmacy left in Oslo that sold needles, this was a catastrophe. Luckily, it was immediately acknowledged that clean needles had to be available to prevent HIV transmission, and several needle exchange programs were initiated from 1987. First in Oslo, but pretty soon nationwide. In addition to secure the availability of needles itself, it was also heavily focused on education and behavior and injecting practices. What HIV concerns, this campaign was a success, and the prevalence of HIV is very low. I think there is 8 persons a year who are identified as new HIV positive from the total population. What concerns injecting drug use. What is my point by mentioning this and going back in time? I will try to give some reasons. Today we have somewhere between, and that compared to HIV, 10 to 15,000 persons showing signs that they have or that they have been affected by hepatitis C. That is quite a huge number. And most of them are injecting drug users. The simple learning from this is that the success in avoiding hepatitis among people who use or inject drugs, we have to do more than secure clean needles and additional harm reduction measures is also needed. In some reports you say that you need to have harm reduction, you need to have needles, but that is not enough. That is what I try to make my point. Others maybe will concretize this further. What seems to be a more depressive part of this impression is that hepatitis have been ignored. It is a kind of, so what, this is part of life, seems to have been the attitude. And what probably is the grimmest part of this picture is that the society's ignorance and lack of responsibility, it have transmitted, excuse the expression, over to users. Your life is not valued more. From my learning as an outreach worker, also to say that these people, but this is what we have to expect. What the professional tried to say then, that is for on several other areas as well, what for they was everyday life would for me be shocking experiences, and they tried to mirror it and to say that you should not accept it, neither that hepatitis is a kind of everyday life. This impression was far from confirmed it was confirmed 2.5 years ago when our ministry, they launched a new strategy on hepatitis as a follow-up to the WHO resolution in 2014. This strategy was heavily criticized for not taking the problem seriously and only focused on prevention and not on treatment. The authorities admitted that medicines was available at that time, but too expensive. Partly also that users would not be able to follow the regime it takes to, take the medicines. Whether it was this criticism, particularly from users, organizations, if that is the reason, or it would have happened anyway, I do not know, and no matter why. Meanwhile, the authorities have been able to negotiate an acceptable price for the cure. And the optimistic message now from one of the responsible doctors in Oslo Hospital is that at the end, the positive message that those who are infected may now receive treatment, and that he finds it likely that we will be able to eliminate this infection. And then I'm back to what I promised Judith when she asked me to bring a message and a conclusion to this side event. Compared to drugs, which are often mentioned here, and it is said that drug use disorder, or whatever you call it, it is preventable and it is treatable. Well, I am a bit doubtful what that concerns. But when it comes to hepatitis, I would say that hepatitis is preventable and it is a treatable disease. So just let's do it. Finally, I will just mention, and this is not a promise, this is what might happen next year. But by several organizations, because Norway is member of CND for the last year will be next year. And we have an ambition to have a resolution every year, and they have had it, well, the first, the second, and the third year. They have been, HIV related, all of them. Some says to finalize this, it would be logical to say that the last resolution, that would be 2019, it should be on hepatitis C. I say this is not a promise, but it is I can see it is a possible option. We have to consider some other options as well. But what I can say is feel free to influence us, and maybe you will also try to convince us. But then we will need help. Thank you.
Thank you. So we have a positive ending to the story from Norway, and I'm going to introduce Jean-Michel Tassié to give the French perspective. Thank you. Yeah.
Good morning, everybody. I'm Jean-Michel Tassié. I'm a medical doctor working in the French Ministry of Health in the office in charge of HIV, hepatitis, tuberculosis, and STI. So thank you very much to invite me to present the French national perspective towards hepatitis C among people who use drugs. So background on the access of direct-acting antiviral drugs, so the curative treatment for hepatitis C, which is available on the market since 2014. Before we had it, but in a research perspective, which was a bit different. So since 2014, it's under the universal French health coverage, 100%, taken in charge 100%. In 2014, this treatment was recommended according to criteria of liver fibrosis or comorbidity, and under the regulation that all prescriptions should be validated by a mandatory multidisciplinary meeting in hospital. In the evolution in 2016, we changed the recommendation to universal access, keeping the same process of mandatory multidisciplinary meeting. That means that all patients with chronic HIV infection could be prescribed and free of charge this treatment. And last year we simplified the process, keeping only multidisciplinary meeting for complex cases. For the moment, the treatment is still has still to be prescribed by specialists in hospital. And this year we are conducting consultation regarding civil society with specialists to simplify and to enlarge the process. Where are we with the data? I come back to a little bit to old national estimates, 2011, because it shows the distribution by risk group. And you see that at this time, we were close to 200 people, an estimate of 200,000 people with chronic hepatitis C, and with around 25% among drug users, and another very big population, it's the third column, and a very big group, it's migrants, around 25%. That is that there's a really real specificity of this epidemic that affects a large group of people with limited access to care. We have really to consider this situation and the rest of the population, of course, is more general population at the time of non-A, non-B hepatitis C. Where are we now? We had approximately 60,000 people treated with DAA by the end of 2017. At this moment, we estimate that 100 to 110,000 persons have chronic hepatitis C and are eligible for the treatment. With the problem of limited access to testing, we estimate in 2014 that 75,000 people were not tested, so a huge proportion at this time that need to be tested. And what I was saying also, this high proportion among key population with limited access to care. So two very great points, testing and improving access to care, consider in the strategy. Just a word in the situation in jail, just related to the care, the curative treatment. There are some, which is available as in the, as on the common right, it's available in prison. With problem of acceptance of testing and also the problem of in-out follow-up when treatment is prescribed in prison for short stay. Now, some line regarding reinforcing the elimination strategy, considering the cornerstone that the curative treatment is prevention, and with a strategy that should be dedicated to all vulnerable people, migrant, drug users, general population, but with specific approach related to drug users because of the transmission reservoir. To remind that treating one drug user will prevent 10 transmission, 10 infection. So what are the big lines? First, what I was saying, reinforcing testing in a combined approach for the three viruses, HIV, HCV, HBV. We still face hidden epidemic of HIV, and we need to combine the strategy of testing. And by the strategy of testing is for the general population and also by outreach strategy for key population. Developing point of care for vulnerable people within structure dedicated for drug users, for example, We have in France important supported harm reduction program with the NSP, and we have around a network of around 500 supported structure developing harm reduction and NSP. So we have to think about point of care for hepatitis C and other diseases in this structure, but it's not only a question of regulation and to upgrade this structure for such care. It's also to give support related to. I take the example, last year we implement rapid testing in the network of harm reduction. It's the HCV rapid testing. It was not so easy for the structure to get it. They need support. So that is my other point. We have to work on integrated support between hepatologists and addictologists. We have really to make these two specialties communicate in a supportive way. Some structure dedicated to drug users will manage by themselves, but others will need support of hepatologists. So it's really a big line. We want to work on it. Thereafter, also to work on the enrollment of all health professionals in follow-up. Task shifting for nurse, for example, for fibroscan, for screening, for testing. We have already some pilots, but it's not developed enough. And also the place of pharmacists in delivering the treatment, because we have fears about some interaction too. We have not to neglect that. And the pharmacist, by the system we have in France and the pharmacist file, we have possibility to have really a good vigilance of the risk of interaction. Also questioning pilot strategies to reach those out of care. We estimate that around 50% of drug users won't go to this structure. So how to reach these people? Mailing, etc. We need some pilot. Now the political framework, la stratégie nationale de santé 2018-2022 have been published, and hepatitis is addressed. And now we are awaiting the launch of the operational plan, which is the Programme National de Santé Publique, which is a multi-sectoral plan, and this plan will be launched in the coming weeks. And so we have great hopes regarding to hepatitis, and also the plan NILBECA, which is the multi-sectoral plan for drugs and drugs. That was a very quick picture, and I thank you for your attention. And I want also to thank the Fédération Addiction, who is a French NGO on drug users that supported my project.
Thank you. Thank you very much, Jean-Michel. I think France is an inspiration, and this story is unusual and dramatic. The 60,000 people to be treated is a triumph of organisation and effort by many people.
That, yeah.
Very, very good. There are other countries in the world, and I think Egypt, Australia, Iceland, some countries have taken particular effort and have already heading towards elimination of hepatitis C, and France is a good example of how we can all, the rest of us can follow. The UK is far behind, but is following on your heels, possibly as usual. I would like to introduce Bikas, who will also introduce himself. Thank you. I'm sorry.
Hello everyone, good morning. My name is Bikas Gurung, and I work with the Asian Network of People Who Use Drugs, and my role as a speaker at this side event is to bring the perspective of people who use drugs in the hepatitis C response. So, and everything I tell you here is indeed like coming from the people who use drugs, because we went through a consultative process for whatever I'm going to tell you here, and I'm going to tell you the truth that you need to know about people who use drugs. So first, let me talk about the different roles of people who use drugs on hepatitis C response. So I'll start by reminding that people who use drugs are typically excluded from Hep C treatment opportunities due to the ill-perceived risk of discontinuation from the treatment course in many countries. But studies of direct-acting antivirals have found that people on oral substitution therapy, including those who continued to use illicit drugs, maintained good adherence and had high sustained response rates comparable to those of non-drug users in the trials. I have known many friends who have self-medicated with Indian-made generics and have cured their Hep C. One may wonder, like, why on earth would drug users buy medicines for themselves and cure on their own? Like, this is something that we need to like consider. Like, of course they will, because people who use drugs are not inherently enemy of their own lives. So treatment in many cases begins with like prejudices, and often physical discomfort is misunderstood as withdrawal symptoms. Governments and healthcare providers should understand that successful treatment often depends on having the right systems in place rather than focusing on drug use behavior as the unit of analysis. Mobilizing the community of people who use drugs has been the most effective way to reach out the hidden peers in both HIV and Hep C response. May it be through some funded projects or in an individual capacity, we have been supporting our peers with the right prevention and treatment messages. Various misconceptions on Hep C still exist in every country. The reality is that people who use and inject drugs are unaware that they are infected, and Hep C treatment access is very low. We have been an educator and a support system for our friends who undergo the screening and treatment since the era of PEG interferon. We have been there to share happiness when some of our friends were cured. We have been there to look after when some of our friends were reinfected and those who were like hospitalized due to some side effects. And we are always there to mourn when our friends die due to Hep C and other health issues. The essence is that we make up a good peer educator outreach and support system, and meaningfully engaging and mobilizing our community is the best chance our governments have to respond hepatitis C epidemic. I'm privileged to work with many fellow activists who relentlessly are in pursuit of serving the community through whatever means. People who use drugs in most of the countries have been supporting their peers residing in different countries to access affordable generics without worrying about the regulatory barriers. Governments could have made the access to generics much easier, faster and cheaper, but since they have their own lucrative business to take care of, we have taken the responsibility on our own shoulders. It is not only our community that we have served everyone who were in need. So I will share you one short memory. Like, recently in Thailand, we assisted someone to purchase Indian generics. We do not know like if she was belonged to our community, but she had cirrhosis and her doctor had prescribed sofosbuvir and daclatasvir for 6 months, which would cost her $5,000 per month. We were able to get her into medication in $1,000 for an entire 6 months. So her daughter regularly updated us for her progress with her recovering and smiling photos, as if she was like saying us thank you for the support we did. And this kind of like when we are able to save someone's life, then this comes to us with an unimaginable level of determination to break the rules and regulations every time, again and again, to save lives. I will not go further in depth about the price and regulatory barriers, and I'm not an expert of those kind of things also, but I have to mention price and regulatory barriers here because there is a role of community advocacy to overcoming it. In the early 2000s, significant price reduction on effective HIV medicines from several $1,000s per person per year to below $100 led to substantially increased access to antiretroviral treatment around the developing world. This did not happen out of the blue, but rather required a combination of mechanisms, including huge advocacy movement led by affected communities. unlike the global HIV response, it is unfortunate that we do not see the same level of support for people who use drugs to perform advocacy. The price of DAAs may have reduced, but it is not accessible to everyone across the region, and these days diagnostic costs are even higher than the medicine itself. Despite all the hostilities that our community face, national networks of people who use drugs in Indonesia, India, Vietnam, Thailand, Nepal have been advocating to overcome these barriers. For instance, since 2010 in India, community and civil society groups have been actively opposing free trade agreements. They have filed several pre-grant oppositions to the Office of the Controller of Patents for numerous DAAs. The Indian Drug User Forum sits on the Committee for National Action Plan for Viral Hepatitis and has successfully pushed for prevention and treatment of HIV/Hep C co-infection with the Global Fund and the Ministry of Health in India. PKNI, the National Network of People who Use Drugs in Indonesia, is one of the strongest activist network in the Asian region. Through their collaborative advocacy efforts, thousands of our community members are benefiting from treatment. Similarly, the Vietnam network of people who use drugs have been advocating to include Hep C under their universal health coverage schemes. Community groups in Thailand, Myanmar, Malaysia, Cambodia, Nepal, and other countries have been advocating for affordable diagnostics and treatment of Hep C. The essence is that inside every person who uses drugs lies a great activist. We must build the capacity of people who use drugs in these issues and engage them to more effectively organize, advocate, and be part of the solution. So these are the roles that we have been playing as from the community of people who use drugs. But now I will talk about some of the barriers that we face during performing our roles. In the realm of HIV, it has been long established that criminalization and punitive approaches prevent people who use drugs from accessing life-saving care and support services. After almost 30 years of reiterated message, here we are now trying to explain the same for Hep C. It is very important that all of us know the reality that we have been forced to suffer through at least 3 major crises. 1, infection of blood and airborne diseases. 2, overdose due to massive drug contamination. And 3, the so-called war on drugs. The other important thing that we must be aware of is we are not the priority. It is as simple as that. Not that there has been no progress, certainly there are, but when we talk about people who use drugs, we are simply not the priority. We have been denied from participating in clinical trials, from various opportunities, and from forming our own organizations. Not prioritizing for health services is one thing, but we have been the targets of politically motivated war. Asian governments are killing people who use drugs like some stray animals. In the Philippines, over 20,000 people have been brutally murdered since June 2016. Over 65,000 people have been arrested. Those in prison are forced to sleep piled up on one another due to overcrowding. In August 2017, they killed 32 people in one night because they were suspected of drug use. They were suspected. They even do not know whom they have killed that night. So similarly in 2017, it has been reported that Indonesian government carried out extrajudicial killings for at least 107 people who use drugs. Cambodia declared war on drugs and arrested 17,000 people. I have to quote our fellow activist from Nepal, who was one of the activists during the AIDS crisis. He said, "I have lived with HIV for nearly 20 years, and even during the AIDS crisis, I did not lose as many friends in any given day as we are losing them today since the crisis began." So last month, in the 37th session of the Human Rights Council, UN High Commissioner for Human Rights raised the issue. Some states view human rights as of secondary value, far less significant than focusing on GDP growth or geopolitics. While it is one of the 3 pillars of the UN, it is simply not treated as the equal of the other 2. So this should be our question, like seriously, why is the UN, why is the human right not the priority for United Nations? Member states are like being pushed or in some cases forced to ratify the UN drug conventions. The Universal Declaration of Human Rights that came before the drug conventions is simply useless when it comes to protecting our community. It would be more appropriate to say that human rights are not universal, but violations of human rights are rather unfortunately universal. So for more than half a century, people who use drugs have been defined either as a social evil or the people with chronically relapsing brain disease. We are perceived by many governments and societies as their enemy. Many see us as public nuisance while others as victims. Many think that people who use drugs are not functional. Many think we are beyond redemption and our brains have been melted as a result of drug use. To conclude, unlike what our governments and societies think of us, I have shared the vital roles of people who use drugs at different levels of responses to eliminate Hep C, as a patient to peer support, as a Hep C prevention outreach to an advocate. We have contributed equally, if not more, to the global HIV response. We have organized our community at national, regional, and global level. There are organizations led by our communities all around the world supporting peers to access health services, protecting peers from human rights violations, saving lives of peers from overdose and other health issues, saving peers and the societies through harm reduction messages, advocating in collaboration with many stakeholders for evidence and right-based drug laws and policies at different levels. We, who you have known as junkies, have been doing all of it in the context where we are criminalized, where we are highly stigmatized and discriminated, where we have been abused, tortured, incarcerated, and extrajudicially killed. We wonder how many thousand times more effective we could have been in presence of enabling laws and policies that are evidence-based and that respect basic rights of people who use drugs. This system, the current system, at one breath promises us health and well-being and dehumanizes us on the other. We do not need this kind of system that victimizes people. We do not need this kind of system. We need to have a system that do not treat people differently. How is it even possible to envision elimination of viral hepatitis when our organizations and communities are not considered as allies? UN and the country governments must acknowledge the level of effort our community has made to achieve the SDG targets. They must begin to see us as well as engage us as the ultimate solutions. There is nothing for us without us.
Thank you, Bikas. A powerful explanation of why we definitely do need the people who use drugs to help us in this bid to eliminate the world of hepatitis C, but also to do so much else. And in the UK, certainly, the peer support systems in my own town are part of what is helping the people who use drugs to understand, number one, they haven't been tested even. Number two, they don't know what hepatitis C is. And number three, they certainly don't know necessarily that it can now be cured with no side effects. And the old days of interferon, which people assumed were still here, have gone. And we can now, and we need the peer support systems to be supported in every country to get this message across. So I'm going to hand over to Céline. Thank you, Céline.
Thank you. I don't know if we still have maybe a few minutes. I will try to shorten my presentation. So thank you everyone for being here, especially on this last day of what has been a very intense week. And also thank you very much, Bikas, for your powerful statement and bringing the voice of community, which decisive role is too often being ignored. My name is Céline Grillon. Sorry. I work with the French International Medical Organization Médecins du Monde, also known as Dr. But I am also here representing the French Civil Society Platform on Drug Policy, and therefore my presentation will include elements from both domestic and international experience. I must say I am really happy to have the opportunity to talk about hepatitis C here at the CND, where I design drug policy that do impact in such a determinant way our healthcare programs and, most importantly, life and well-being of people. I would like to start my presentation by recalling the target of the global strategy on viral hepatitis, which are to reduce new infection by 90% and deaths by 65% by 2030. The hepatitis C epidemic disproportionately affects people who use drugs, both in prevalence and number of new infections. In other words, hepatitis elimination is foreseeable, but we will not achieve it if we fail to reach people who use drugs. This is why the World Health Organization has identified harm reduction as a core intervention in the global hepatitis strategy, with a service coverage target of 300 sterile needle and syringe provided per person to inject drugs per year. While the past 2 years have shown great progress in access to treatment, currently the epidemic continues to grow, and people who use drugs get left behind or progress is made. We therefore need urgently concrete solutions to scale up HCV prevention and treatment for people who use drugs. Identified challenges are multiple: insufficient data for informed intervention, lack of awareness and misconception within the drug-using community about Hep C and treatment opportunities, and insufficient access to prevention tools. In too many countries, evidence-based interventions such as needle and syringe programs remain excluded from national policies. Even in countries which integrate harm reduction in the public health policy, access can be insufficient. Like, for example, in France, where it has been documented that still 1/3 of people who use drugs have difficult access to sterile material. Other challenges include poor access of people who use drugs to HCV treatment, which result from different factors such as very expensive diagnosis and medicine, treatment restriction based on drug use, highly centralized care, as well as stigma and discrimination. The latest applies also to healthcare providers who often wrongfully suspect disinterest or lack of motivation from people who use drugs, presumption of poor compliance, and worries about reinfection. Stigma also puts people at greater risk of economic vulnerability, which has been documented to impact health outcomes and lead to a vicious circle creating more stigma and more vulnerability. On the other hand, drug policy and criminalization of people who use drugs also fuel the epidemic of hepatitis C. Prohibiting injecting paraphernalia possession impedes harm reduction service delivery and uptake, restricting access to effective means of protection against HCV transmission. Moreover, people who use drugs are frequently incarcerated or extrajudicially detained, often leading to interruption of medical treatment without access to prevention and other harm reduction services, and increasing risk of hepatitis C infection. Policy criminalizing drug use also fuels stereotypes and negative assumptions of people who use drugs, ultimately reinforcing stigma and discrimination. Now, I would like to quickly present some recommendations issued from our experience as service implementers. 1. Universal access to HCV prevention and treatment, which is a basic human right. Effectiveness of HCV treatment among people who use drugs has been largely demonstrated, such as effectiveness of needle and syringe programs and opioid substitution treatment or therapy in preventing new infection. There is no justification for denying those life-saving interventions to people who use drugs, and often it is connected with other reasons such as expensiveness of treatment. Let's remove treatment restriction and join effort to scale up harm reduction and ensure access to affordable treatment, including in prisons. To be effective, we must design and implement adapted models of care which are comprehensive, patient-centered, and decentralized at community level. Harm reduction services as entry point to hepatitis C care, diversified and non-invasive screening methods, and strong peer support are effective ways to bring people who use drugs into treatment programs. Increasing knowledge and implication of people who use drugs by associating them in the design and implementation of programs and policy. It is too often said that people who use drugs are hard to reach. The truth is that they are easy to ignore. The best way to engage people who use drugs in programs is to consult them on how programs should be designed in order to meet their needs. This is also what harm reduction is about. Fighting stigma and discrimination, including among healthcare providers through training, workshops, and other activities, and monitor the progress by including stigma-related indicators in health policy. Of course, countries need to dedicate funding from domestic or international resources to finance the hepatitis C response, which is already the case of several countries, including low and middle income. And finally, and this is of important concern here at the CND, we need to reform laws and policy to create an enabling environment for our health policy to be successful. We therefore recommend the removal of all barriers hindering access to harm reduction services, the criminalization of minor non-violent drug offences, and more generally the adoption of an approach based on public health and promotion of human rights. In this regard, I would like to quickly talk about a declaration that has been published by the hepatitis C community, together the drug using community, hepatitis C patient, NGO, medical community, and researchers. The declaration has been published at the World Hepatitis Summit held in Sao Paulo last November. And this whole hepatitis community, coming from different backgrounds, came together in recommending this drug policy reform. So I think it is important to bring their voice here in the CNT where drug policy are made. So my last slide is a few policy recommendations for the CND. One, to implement the paragraph of the UNGAS outcome document which relates to measures such as medication-assisted therapy and injecting equipment programs to prevent transmission of viral hepatitis and other services defined in the UN technical guidances. To adopt a CND resolution on hepatitis C to guide the action of member states to tackle hepatitis C among people who use drugs with evidence-based intervention. To ensure that hepatitis C is adequately addressed in the post-2019 global drug strategy, and more generally, to align drug policy with the Sustainable Development Goals, health-related objectives and scientific evidence, and to include health-related indicators in global drug policy. Thank you.
Thank you very much. I'm sorry, we need to applaud, but I'm sorry we do have to leave the room without any more debate, unless we can debate outside. I hope we can take this message forward, and that we all need to work together, particularly with the peer support and with the regulators and with the doctors and with everybody else working together. We can rid the world of hepatitis by 2030. Thank you.